Good afternoon, everyone, and welcome to the North Dakota Department of Health Town Hall on COVID-19 vaccine boosters. My name is Molly Howell, and I'm the Immunization Director for the North Dakota Department of Health, and I'll be moderating our discussion today. And with me, I have a few other speakers. So our first speaker will be Kirby Kruger. He's the Section Chief for Disease Control at the North Dakota Department of Health. He has been with the Department of Health since 1989, working in infectious diseases and injury surveillance. Then we will have Dr. Paul Carson, who is with North Dakota State University, Department of Public Health. He has over 25 years of experience in various clinical capacities, and he works with the North Dakota Department of Health on many projects, including healthcare-associated infections, antimicrobial stewardship, and vaccine education. And then we also have Vanessa Riley with us from the North Dakota Long-Term Care Association. She is the Director of Emergency Planning for the North Dakota Long-Term Care Association, where she works with long-term care facilities in North Dakota to assist them in being prepared for unexpected emergencies. The North Dakota Long-Term Care Association is a professional and advocacy organization representing assisted living, basic care, and nursing facilities in North Dakota. Additionally, we have a few other folks on the line in case there are any questions after that we can call on to help us answer some questions, including Tim Wiedrich, who is the Section Chief of Health Resources and Response for the North Dakota Department of Health, and Jenny Galbraith, who's the COVID vaccine manager with the North Dakota Department of Health. And so to start us off, I'm going to turn it over to Kirby Kruger, who I believe has a few slides and is going to update us on what's happening with COVID in North Dakota. Kirby?
Thank you, Molly. And I do have some slides here. I'll see if I can get them shared. And hopefully you're seeing the slides. And good afternoon, everybody, and I appreciate you taking time out of your busy schedules to join us today. I just want to provide a quick overview of where we're at with COVID-19 and the state of COVID-19 in North Dakota today. This is just information that is gathered by the North Dakota Department of Health and published every day on our dashboard, and we're at 4,339 active cases. You can see that our cases continue to increase. Our slope continues to go upwards, and our 14-day positivity rate is averaging just a little over 7% for our testing. Looking at total positives, you can see we had our big peak back in November last year, November of 2020. We had a relatively quiet spring with a little bit of an increase in right around April there, but then you can see we had a nice summer, lower numbers, but our cases have been increasing since late July and are continuing to increase. We're hoping that we'll plateau soon, but we don't know where we're at on that, and that's hard to predict. And so, but that's where we're at today in terms of cases. Today we had just a little over 700 cases reported. And then looking at the age structure of our cases, there's two charts here. One is the active positives of the people who are in that 10-day active window with their infection. You can see the age structure there. And for those active positives, they make up about 28% of our cases. When you look at the age groups 0 through 19, they make up about 28% of our cases now. When you look at our cumulative positives, you can see the structure has changed a little bit. And really, cumulatively, we're at that age group, those younger people are at 19% of the total cases. So you can see that the younger population is being proportionately impacted a little more this surge than it was a year ago with the previous surge. And then this is a busy slide, and I know that this is hospitalizations. Today we had 155. We reported out 155 hospitalized individuals due to COVID. Of that, 20 are in ICU. I think what I really wanted to point out is that this 155 is really the highest number we've had since our last peak and a year ago. And so we are, if I look at a piece of good news in this, it's that the rate of increase is not as steep as it is for the cases, and that, to me, that is good news, that the hospitalizations aren't increasing as fast as our cases are. And so that's the piece of good news. Just looking at the age structure for those who are hospitalized, the top chart is the cumulative age structure, and then the bottom chart is just those who are currently hospitalized. And you can see just currently hospitalized, we have 5 pediatric cases actually in the hospital right now. Our Office of the State Epidemiologist, they put together this chart for us here today. And this is really looking at North Dakota data, looking at vaccination rates by county, and then looking at hospitalization rates by county. So we're looking at hospitalizations on the vertical axis, hospitalizations per 100,000 population per county, and then on the horizontal axis, we're looking at vaccination coverage rates. And there are 53 dots on this chart. Every county has a dot. And you can see that there is a correlation between higher vaccination rates and lower hospitalization rates. In other words, what we see is that as vaccination rates increase, there is a general trend to have decreased hospitalization rates for those counties. Now, there are some outliers that you'll see there, and they're actually named. Slope County there, which has a moderate hospitalization rate, but a very low vaccination rate. Then you have Emmons County there that has, a little bit, has a high hospitalization rate and a moderate coverage for their vaccination. And then you have Nelson County, which has a very high vaccination rate, and they have a moderate hospitalization rate. So there are some outliers, but when you look at the data overall and you look at the significance of it, there is a significant correlation between the vaccination rates and decreased hospitalizations. And then just looking at yearly trends, just where we were last year compared to this year, this is active cases, and you can see we have a little bit of a jump over where we were at the same time last year. We have more active cases right now than we did at the same time last year. And then this is just new cases, daily cases reported, and 14-day average, excuse me. And then we're still a little bit ahead of the curve there on that. Our fall is starting out a little bit more rapidly than we were a year ago. And then just looking at our testing is also up, and we're testing more people and running more tests than we were about a year ago at this time. And that's a good thing. If people need to be tested, they should be tested, and they should be seeking that testing. And then our testing positivity, that started out, we had much higher positivities early on, but now it's starting to correlate more closely to where we were last year for positivity. And then I want to talk a little bit about the variants. CDC recently changed the way they classify their variants. It wasn't a significant change. They basically added a new category to the other categories, and that category being variants being monitored. Previously, we had 4 variants of concern. Now there's only 1, and the other ones were moved to the variants being monitored category. And those variants being monitored include the alpha, beta, gamma, epsilon, eta, iota, kappa, the B1617.3, mu, and zeta variants. And then So those are the ones that are being monitored. We have variants of interest. Right now, there aren't any that CDC is classifying as a variant of interest. And then the variants of concern, that is down to one, and that's the Delta variant, and which is really the primary variant that's circulating in the United States and throughout most of the world right now. And then the last category is the variants of severe consequence, and they do not have any virus variants in that particular category. And this is North Dakota data. This is for our variant surveillance, and this is the most recent report from this week. And what we have there is the different colors indicate the different variant viruses by week. And going back to early October of 2020, what we have there is that blue color indicates other variants that indicate our earlier variants of the virus that are really no longer circulating. And then as we moved out of 2020 and into 2021, what we see emerging is that dark gray color in the bars. That is the Alpha variant, and that continued to be the predominant variant through most of the early part of 2021. And then in early summer of 2021, late spring, we start seeing the Delta variant emerge. That is that greenish blue color that you see that predominates this graph that for the last part of through the last part of the summer and into the fall of 2021. And so you can see from our surveillance that it's the Delta variant that is predominantly what's circulating in North Dakota. All right, that's all I have, Molly. So I'll just turn it back over to you. So.
All right. And thank you, Kirby. And we'll have an opportunity for people to type in their questions. I'll turn that on in just a little bit, but I'm going to turn it over to Dr. Paul Carson to talk about COVID vaccine effectiveness, and then, of course, also touch on vaccine safety. Dr. Carson?
Thank you, Molly, and thanks, Kirby, and thanks for having me to be able to share some of this data and information on where we're kind of thinking with the boosters. So first, just a little bit of an update on where we're at with vaccination in North Dakota in general. So for the 12 and older category, people getting at least one dose of the vaccine, we're at almost 61%. Fully vaccinated, 52%. That still puts us, I think, probably somewhere in the bottom 5 states in the country for fully vaccinated population. It goes up as we get into older age groups. So North Dakota, 18 and older, having at least one dose, 63%. Gets up a little bit there further, approaching 55% for fully vaccinated. And then in the older age group of 65 and older, we're at 86% of the over 65 population having at least one dose, and almost 77% being fully vaccinated. And it's not homogeneous across the state. We have a lot of variability. You can kind of see the lighter colored counties or the lower vaccinated counties. The darker blue colored counties are the more highly vaccinated counties. So we have a lot of disparities across the state at the regional or county level. When we look at vaccination rates in one of the places we care a lot about, which is skilled nursing facilities, where there's a much more vulnerable population, we can see in North Dakota we've got about 92% of our skilled nursing residents vaccinated. And we're up there. We're amongst the ranked about number 4 in the top 5 states for our residents being vaccinated. So that's something to be very proud about. When it comes to our staff or healthcare personnel working in those facilities, we've got a little room to improve. We're at about 64% of our long-term care staff being fully vaccinated, and you can kind of see how we sit in relationship to the rest of the states on nursing home staff being fully vaccinated. When we talk about the vaccines, we're concerned about both safety and efficacy. And so one of the big concerns about is what's happening with the efficacy of the vaccines. And I want to kind of touch on that first. So at the beginning, when the FDA had set goals for where the vaccine needed to land to consider it for authorization. They'd set the bar at about 50% efficacy, meaning it would reduce infections in the vaccinated group by at least 50%. The initial clinical trial data, it was 94 to 95% for the mRNA vaccines, a little bit lower for the Johnson & Johnson vaccine, but this, markedly exceeded our expectations, and there was a lot of happiness about where we landed with that. But we started to kind of see some of that getting eroded away to some degree over time. We were getting data from other countries, and here we kind of see vaccine effectiveness. That's, how well, again, it protects, or how much it reduces the likelihood of infection in that vaccinated compared to an unvaccinated group. And out of England, the blue dots here are the pre-Delta, really the alpha, during when alpha variant was circulating. You can see it was above 90% still, but coming down a little bit for infection, down to 79%, symptomatic infection down to 88%, but still good against hospitalization, even with the Delta circulating, still sitting at 96%. Canada only saw a little bit of erosion in symptomatic infections, went down to about 85%, still very good, even with Delta circulating against hospitalizations and deaths. The most worrisome data was coming out of Israel, where with Delta, they were reporting vaccine effectiveness as low as 39 to 41% for any infection or symptomatic infection, although still quite good against severe disease, such as hospitalization and death. Qatar also was quick to immunize, so we had some early data out of there, again kind of showing that falling rates of against symptomatic infection, down to 54% with the Delta circulating, but still pretty good against hospitalization and death. And there are some reasons why we might expect vaccine effectiveness to decline. We know that there's sometimes decline in our immune response over time. So the further out we get from our original vaccination, our immune system can wane. There's the possibility that the Delta variant has changed enough from the original strain and from the vaccine spike protein that was induced that it might be different enough that those antibodies to that original spike protein might not be quite as effective. And we know that as people age, they might not make as good of an immune response. And a lot of those things overlapped. I mean, the first people to get vaccinated were the elderly, so they're the furthest out from the vaccine. And that time away from that initial vaccine is when the Delta variant started to circulate. So all of those might come into play. But we have some data now coming from the United States that's giving us a little more insight into this. And this is a little bit of a busy graph, but this is basically showing out of a big database from New York about the vaccine effectiveness over time in the state of New York. And so the dashed black line is sort of the overall vaccine effectiveness over time. You can see it was above 90% back in May and going into early June, and then started to drop over time, especially as we got further into when Delta variant was circulating, but also further out from when people got their original vaccine. This is the curve against any infection, and so you can see that it dropped and it's kind of plateaued in New York to being around 73% or so vaccine effectiveness now, dropped from that kind of low 90% range. Interestingly, the yellow line here is the elderly, and the orange line is the 18 to 49-year-old age group. So not a big difference, and they're all kind of converging as we get out further in time. So not a huge difference with age. So this would suggest it's more a function of time, at least in that New York data. Contrast that with vaccine effectiveness against hospitalization. We don't care so much about preventing colds and mild flu-like illnesses. We care about preventing serious illness, hospitalizations, and deaths. And this is that from that same data set on how well the vaccines have been working over time against hospitalization. And you can see the black dashed line, which is the overall vaccine effectiveness, is still very good, well above that 90% range. But you can see a little bit of a dip now in the elderly, the yellow line, the vaccine effectiveness in the 65 and older age group, but overall remaining stable at 90 to 95% protection against one of those bad outcomes, such as hospitalization. And now other data coming from other places are showing similar things. So the blue lines here are pre-Delta and then Delta for infection. So this is kind of a CDC database. Here's that New York data. And the red lines are hospitalization. And you can see them also broken down by type of vaccine with the Pfizer and the Moderna here. Interestingly, when they looked at the data in a couple of these studies by underlying medical conditions, so in other words, how well are the vaccines holding up over time if you have diabetes or obesity or other medical problems, and that hasn't changed. So that, and this is hospitalization here. And here's frontline workers, healthcare, particularly healthcare workers, and that's kind of a younger, typically a bit more healthy population. This is against infection, not serious disease, and you can see that decline down, in this case, down to about 66, 67%. So we're seeing some evidence of erosion of effectiveness over time against infection, but preserved effectiveness against severe disease in most people over time. When we look here more closely in North Dakota, out of over 300,000 people who've been fully vaccinated, we've got about 4,600 plus breakthrough cases. About 1.4% of all people who've been vaccinated have had a breakthrough infection. Those, for the most part, tend to be very mild, but not all. We've had over 200 hospitalizations in those breakthrough cases. That amounts to 0.065% of the vaccinated population. And there's even been some deaths, 32 deaths. That amounts to 0.0095% of the vaccinated population. So although severe outcomes are rare, they do happen. And when we look at these severe outcomes, they tend to be aggregated in the elderly, in nursing home residents, and people with several medical conditions. Overall, we now see about 1 out of 72 fully vaccinated people in the state have tested positive for the virus versus 1 out of 11 unvaccinated people in the state having tested positive for the virus. A marked reduction in risk of infection. And not surprisingly, the average age of a breakthrough hospitalization is 73. So if you were vaccinated and you broke through, sick enough to land in the hospital, it tends to be that older age group, as opposed to the average age is 59 now for people being in the hospital and unvaccinated. Sanford makes their data public. This is Sanford Health System data, their most recent release on hospitalizations in the Sanford Health System across all of the Sanford hospitals. And they've got 158 hospitalized people, only 12 of whom are vaccinated. 45 in the ICU, only 2 of whom are vaccinated. And they've got 28 on ventilators, all of whom are unvaccinated. Overall, they have steadily seen in their system 90 to 95% of the people in the hospital, in the ICU, or on a ventilator are unvaccinated. So as far as a health system like Sanford in North Dakota, in the hospital, it does still remain a pandemic primarily of the unvaccinated. But we do need to note that there are a small handful of vaccinated people who are landing in the hospital. One of the things I kind of point out to people, just to kind of give you a heads up on what's likely to come, is something that we in public health call the base rate fallacy. So this is like a headline article from Israel data saying Israel says the Delta variant is infecting vaccinated people, representing as many as 50% of new cases. Now, that's true, but we have to look at what's called the base rate, or what's the denominator here. To give you an idea of that, Israel is one of the most vaccinated countries in the world. In their older adult population, this is about right, about 90% are vaccinated. So if you had 100 people and you've got 90% of them vaccinated, that would be 90 vaccinated people, 10 unvaccinated people. If they all get exposed to COVID, and you had, say, 6 people out of that vaccinated group get infected, and 5 people in the unvaccinated group get infected, you can legitimately say there are more infections in the vaccinated than the unvaccinated group. But just eyeballing this tells you why that's way off and giving you a true picture of what's going on, because the attack rate the percentage of people in the vaccinated group who got infected is only 7% compared to the attack rate in the unvaccinated group being 50%. So just be cautious when you start seeing like there's more vaccinated people now, more and more of them getting infected. As we vaccinate more and more people, that will be the case, but we want to know what's the overall attack rate. When we look at the overall attack rate, it's the news is phenomenally good about vaccines. So this is a publication that was in the major journal for public health, looking at 13 different large U.S. jurisdictions on infection rates, hospitalization rates, and death rates in unvaccinated people versus vaccinated people. And unvaccinated people have 5 times more infections, 10 times more hospitalizations, and 10 times more death than unvaccinated people. Overwhelmingly still strongly beneficial to be vaccinated, even against infection, which I said has been eroding, but this is in the Delta period here, 5 times still overall protection. And we see that playing out in North Dakota. This is on the North Dakota Department of Health's dashboard. And this is, I think, the best way to try and show this data, because you're looking at the cases in that group. So we look at the cases per 100,000 unvaccinated people, that's the gray bars, versus cases in per 100,000 fully vaccinated people. So here's cases, and you can see there are indeed cases in almost every age group across the board, almost every age group in vaccinated people, but they're way, way less than the number of infections per 100,000 unvaccinated people. This would be more than that 5-fold difference when we look at it in North Dakota. And when you look at hospitalizations, it's the same thing. Far more hospitalizations in the unvaccinated than the vaccinated. But note that there are some unvaccinated people, some vaccinated people landing in the hospital, especially as they get older. And then deaths, deaths far more likely in the unvaccinated. But again, we are starting to see some deaths even in the vaccinated people, especially as they get older, especially in the 70s and 80s. And here's the average ages of the vaccinated cases, of the vaccinated hospitalizations, and the vaccinated deaths compared to the unvaccinated cases, unvaccinated hospitalizations, unvaccinated deaths. And you can see that there's an age difference of like 10 to almost 15 years, typically between the vaccinated cases, hospitalizations, and deaths compared to the unvaccinated. So the FDA took up this data and data submitted from Pfizer about a study they had been doing on booster doses to debate, should we approve a booster dose for the Pfizer vaccine, which is the only one that submitted data to the FDA at this point in time. We expect the other companies will do that as well. And so they took this up and debated it. And I should just point out that most of our vaccines, many of them have boosters as part of their series. We all are familiar with the fact that we need a tetanus booster about every 10 years. Vaccines like the HPV vaccine is 2 to 3 doses over 6 months. Hepatitis B and Haemophilus B have 3 doses over, more than a year. Pneumococcal vaccine has 4 doses in children, and those go over the span of about 15 months. Our polio vaccine that we all got was 4 doses over about 4 to 6 years. And the diphtheria, tetanus, and acellular pertussis childhood series is 5 doses over 4 to 6 years. We need often boosters to optimize or maximize our immune response. This often works to give very prolonged immunity after we give enough in a series to boost. This is a little bit of a technological slide, but I bring it in to make the point. This is some of the data that Pfizer just submitted to the FDA. And this is looking at antibody levels that neutralize the virus. 1 month after the 1 month after the second dose in the original virus versus the Delta virus. And you can see 1 month after the second dose of the vaccine, they had pretty good antibody levels. The dashed line is above which is a significant amount. But 1 month after dose 3, they really went up. This is a logarithmic scale. So this is a big jump in antibody levels. And this is in the 18 to 55-year-old age group. This was true even in the elderly. This is the 65 to 85-year-old age group. What they found is basically there was a 5 to 12-fold increase in antibody levels compared with the peak levels after the second dose. In other words, a third booster boosted your antibody levels 5 to 12-fold higher. So that's a marked increase, and they're very good against very good, at least in the test tube, against the Delta variant. And now we also have some clinical data from Israel, because they're ahead of us on all of this. They've been giving booster doses since late July, and now they offer it to all their population over the age of 12. And in a study they published in the New England Journal of Medicine, and one of their public health people testified before our FDA on this, they went from an incidence, that's the number of infections per 100,000 persons per day, of 85 down to 8.8 in the 2-dose group. So these are vaccinated people, and these are the boosted group. So that's the big drop there. And severe illness, which was pretty low in the 2-dose group, again, pretty good against severe disease. So it was a lot lower than infections, but it almost vanished then for the boosted group. This basically restored that vaccine effectiveness to 91% against any infection and about 95% against severe illness. This is kind of what we saw when the vaccines first came out. So they're moving in a much better direction now in Israel. So they also reviewed safety data, and basically this is what we have for safety data. Pfizer submitted their boosted dose group. That was only 306 study subjects that they showed, and it's mostly like test tube data and some safety data. But we also have data that are reported to our already existing surveillance systems called VAERS and VSafe. About 12,000 people in the U.S. As of, I think it was about mid-September, had reports on safety from a booster dose, because we'd been boosting immunosuppressed people and some others. So this is mainly that immunosuppressed group. But we've got data on safety of a third dose from almost 12,000 here. And then we've also been able to review the safety data from Israel in their rollout, and they've put out about 2.8 million boosters for ages 12 and up. And in all three of these data sets, it's showing roughly the same thing, that the routine side effects such as a sore arm, fatigue, fever, muscle aches, headache, are about the same to better than what people saw after their second dose. Tends to be a little bit better. And in the Israel data, interestingly, one of the side effects we care a lot about with the mRNA vaccines is myocarditis, or that heart inflammation, which was seen especially in younger males. They really didn't see it with the booster dose. They only had one case, and it was in a person over the age of 30. They didn't see any cases, and they had, if my memory serves me right, over 100,000 people in each of even the young age groups. So they had a pretty good amount of data. So that was very encouraging to see. So I think that's it, and I will stop there.
All right. Thank you, Dr. Carson. And so I am up next, and I should let everybody know that I did open the Q&A. If you want to type in your question in the Q&A, we'll get to that after the presentation. I am going to just talk a little bit about now who should be getting boosters in North Dakota. And so let's see here. Hopefully everyone can see my slides. All right, so who should be getting booster doses in North Dakota? And just to verify, Dr. Carson, can you see my slides?
Yes.
Okay. So this is an infographic that the Department of Health posted on our social media last week depicting who should get boosters. And actually, as of last week, over 80,000 North Dakotans were likely eligible to receive a Pfizer booster dose starting last week. And already we have over 8,000 North Dakotans who have received a third dose of COVID vaccine. And so CDC's recommendations for who should receive a Pfizer booster dose, and please remember all of the booster dose recommendations are just for the Pfizer vaccine. They're recommending that a single booster dose of Pfizer vaccine 6 months after completion of the initial Pfizer vaccine series for people 65 and older, And that's really because of the data that Dr. Carson showed about the waning effectiveness against hospitalization for people in that age group. And then, of course, people living in long-term care facilities and people ages 50 to 64 with underlying medical conditions. And again, that's because we do know that people who have underlying medical conditions are at higher risk for more severe outcomes from COVID. And so even if they got a breakthrough infection, they could potentially have more severe outcomes. And so we wanted to give them an opportunity to receive a booster dose. And so what are the underlying medical conditions that put you at risk for severe COVID? There's actually quite a number of them. And so this recommendation likely applies to a high number of North Dakotans. And so if you have cancer, being treated for cancer, chronic kidney disease, lung disease, dementia, anyone with diabetes is at high risk for severe COVID, Down syndrome, various heart conditions, HIV/AIDS, people who are immunocompromised, and that could be due to a condition that you might have, or it might also be due to any medications that you're taking, chronic liver disease, people who are overweight or obese, women who are currently pregnant or were recently pregnant. This should say, it should say sickle cell disease. And then current or even former smokers, people who have had solid organ or stem cell transplants, and that should say transplant, those who have had a stroke, and then people with substance use disorders. And all of these are listed on CDC's website. And so if you're between the ages of 50 to 64 and have one of these conditions, you should receive a booster dose. And if you haven't yet been vaccinated at all for COVID, you should definitely consider vaccination. Now, CDC also made recommendations for people who may want to consider a booster dose of the Pfizer vaccine after they assess their benefits and risks, their individual benefits and risks. And these groups include people age 18 to 49 with one of those underlying medical conditions, and then people 18 to 64 who are at increased risk of COVID exposure and transmission because of their occupation or living in an institutional setting. So the occupations that are included in that recommendation are first responders, so that includes healthcare workers, firefighters, police, or congregate care staff, education staff, and so that could include teachers, people who work in a school setting, childcare workers, and then food and agricultural workers, manufacturing, corrections. Those are, corrections is definitely close quarters and at more increased risk for transmission. U.S. Postal Service workers who have continuous contact with people every day, public transit, and then grocery store workers that also come into close contact with people every day. The high-risk institutional settings that are included are, of course, we talked about long-term care facilities, but also people living in homeless shelters, correctional facilities, and drug treatment facilities can all receive a booster dose of the Pfizer vaccine if it's been 6 weeks since they completed the Pfizer series. One question that we get quite often is, are you going to need to show proof of your underlying health condition, or do you need a prescription from your physician, or do you need to show where you're employed at in order to get a booster dose? And the answer is no. You can just self-report that you have an underlying health condition or what your occupation is, and that's all you need to receive a booster dose of the Pfizer vaccine. So I think if you're 65 or older, or if you're in that 50 to 64-year-old age group and have an underlying health condition, CDC is saying you really should receive a booster dose. You are recommended to receive a booster dose. But for other individuals who are younger and may have an occupational risk, or are younger and have an underlying health condition, you're supposed to weigh benefits and risks. And so the potential benefits of a booster dose are are that it can reduce the risk of COVID-19 infection and then, of course, reduce the risk of severe disease. And Dr. Carson showed some really promising data out of Israel after they implemented boosters. The strongest evidence for reduction in severe disease have been in the 65 and older age group, and that's because that's where we're seeing the most waning in effectiveness against hospitalization. And then another benefit is minimizing the risk of COVID infection could potentially reduce transmission to the virus. And so there's not as much data on that yet. It does look promising out of Israel that if we receive booster doses, that we could potentially reduce transmission to other individuals, especially those around us that are at high risk. But there are potential risks of a booster dose that you have to consider. And so one of those is myocarditis and pericarditis. And so what we're seeing with mRNA vaccines is that the greatest risk for myocarditis and pericarditis is in males who are younger than 30 years of age. That age group potentially has a rate of myocarditis of 20 to 50 cases per 1 million individuals vaccinated with an mRNA vaccine. And so this is the inflammation of the heart muscle or inflammation of the sac around the heart. And it can be quite concerning. Everyone seems to be doing fine after and symptoms resolve and they're doing well, but it is something that you want to take into consideration when you're deciding if you want to receive a booster dose. The other thing to take into consideration is that myocarditis post having COVID infection, the rate is 450 cases per 1 million persons infected. And so you kind of have to weigh that to decide if you want to choose vaccination or potentially risk getting COVID-19. The other risk of a booster dose is anaphylaxis, which is a severe allergic reaction after the vaccination, and this happens, almost immediately after vaccination. We don't yet know what the rate of anaphylaxis is after a booster dose. With the primary series, the rate of anaphylaxis is 5 cases per 1 million persons vaccinated, but it's still something to take into consideration. And then, of course, everyone that's been vaccinated, you know that there is the high potential for mild to moderate side effects, including fever, muscle aches, headache. Of course, most of us have a sore arm, and they are common following mRNA vaccine. And so you have to take all of this information in when you're deciding if you want to accept a booster dose. There are other things that you might also want to consider. So what is your risk for a work-related exposure? So let's say you've been vaccinated, but you usually just work from the home, you don't go into the office, you're not exposed to a lot of people. Somebody who's younger might say, you know what, I'm not at that high of risk, I'm not gonna get a booster dose. But if you're in close proximity with others and you often interact with unvaccinated individuals, you might want to consider getting a booster dose. And that could include healthcare workers or teachers who have frequent contact with people who are unvaccinated. Something else you might want to think about is, do I live or work in a congregate setting? Corrections, homeless shelters, long-term cares, they're all at very high risk for COVID transmission and outbreaks due to close quarters. So you might want to consider a booster dose. You might also want to look at the level of community transmission where you live. Are most people vaccinated? If not, am I seeing a high number of COVID cases? Then you might be at more risk for a breakthrough infection. We've talked about underlying health conditions, but the other thing to consider is how many underlying health conditions do you have. If you have more than one, the risk for severe COVID-19 increases as the number of underlying medical conditions increases. You might want to think about if you have frequent contact with someone who's medically frail or immunocompromised. If you're frequently visiting a loved one in a long-term care or caring for someone at home, or if mom or dad have immunocompromising condition, then you might want to consider a booster dose to reduce the chances of transmitting COVID to someone you love. The other thing to consider is if you were previously infected with COVID. And we do know that people who are previously infected with COVID and then are also vaccinated, which you should be, it significantly reduces your risk of getting reinfected with COVID. So people who are previously infected with COVID and vaccinated, or if you were vaccinated and then had a breakthrough infection, you likely don't need a booster dose, at least not right now. And we don't really know what the need is or the efficacy of booster doses in people who were previously infected and have been vaccinated. And then it looks like I missed one. The other thing you have to consider is if you're younger, healthy, and you've been vaccinated, you could get a breakthrough infection, but that would mean that you would have to miss work. And are you okay with missing work or missing personal obligations? And that's something to take into consideration when deciding if you're going to get a booster dose. So what about individuals who received the Moderna or the Johnson & Johnson vaccine? What can they do? Well, right now, we don't have sufficient data or regulatory authority to give booster doses to people who have received Moderna or the Johnson & Johnson vaccine. And so those individuals should not receive a booster dose. I should mention that there is a recommendation for an additional dose for people who received Moderna or Pfizer vaccine and are moderately to severely immunocompromised. An additional dose is different than a booster dose. An additional dose is for people who never received the full benefit of vaccination initially because they were immunocompromised, and they should receive basically 3 doses of the primary series of an mRNA vaccine, and the third dose should be 28 days after your second dose. And so that's different than a boost. A boost is in people who initially did receive the full benefit of vaccination, but their immunity is waning with time, and so that it needs to be boosted, and that's the 6-month booster. Another question that's been coming up is, do I need a booster dose to be considered fully vaccinated? And the answer is no. For public health purposes, people are considered fully vaccinated 2 weeks after receiving 2 doses of Pfizer or Moderna vaccine or the single dose Johnson & Johnson vaccine. You can receive other vaccines at the same time as COVID vaccines, and this includes your COVID booster. And so this fall, influenza vaccine is recommended for everyone 6 months and older. And so if you're eligible to receive a COVID-19 booster dose, please also get your flu shot at the same time because we don't want influenza cases on top of all of our COVID cases, and you can receive them both at the same time and other vaccines as well. So there are a number of places that you can be vaccinated in North Dakota. Over 429 provider sites in North Dakota have enrolled to give COVID vaccine. This includes local public health, pharmacies, private healthcare providers, and then we also have pop-up clinics across the state. You can go to the Department of Health's COVID vaccine locator page. You can also visit vaccines.gov or text your zip code to 438-829 or ndvax.org. If you're not super internet savvy, you can also call our hotline if you're having trouble finding a booster dose. That phone number is 866-207-2880. For those of you who have loved ones in long-term cares, and Vanessa is going to talk about long-term cares in a second, but long-term care facilities have been matched with a primary and a backup vaccinator, and so there will be vaccinators going to the long-term cares to provide booster doses to those who are eligible. Some employers may be offering on-site booster dose vaccination. And then lastly, the Department of Health will send letters to people who are 65 and older who are eligible for booster doses, and we'll offer some assistance there if you're having trouble finding booster doses near you. So just key takeaways regarding booster doses. Yes, vaccine effectiveness against asymptomatic or mild infection is decreasing with time and likely also due to the Delta variant. But even with the Delta variant, Right now, if you're vaccinated with just the primary series, not boosted, you're still 5 times less likely to have COVID-19 and are likely not the greatest source of spread in the community. COVID vaccines do continue to be highly effective at preventing hospitalization and death, but we are starting to see effectiveness decline in those 65 and older, which is why we really want to make sure they get a booster dose if they receive the Pfizer vaccine. The one thing that I do want people to take away is that booster doses are not an answer to ending this pandemic. It will have a small impact, but really what's impacting our hospital capacity, what's causing the majority of the cases are unvaccinated individuals. And so people choosing to be vaccinated who are not yet vaccinated will have the greatest impact on the pandemic and is the priority. And for all of this information, experts are continually monitoring the data regarding vaccine effectiveness, and so recommendations may change in the future. And if you have any questions about booster doses or COVID vaccine, you really should talk with a trusted healthcare provider. I did want to just touch on COVID vaccine in children because I know that was in the media this week. Pfizer has submitted some data to the FDA regarding its clinical trial in children ages 5 to 11. As a reminder, the Pfizer vaccine is available for children ages 12 to 17. The clinical trial in younger children is still a 2-dose series, and it is a lower dose of the vaccine than what's given to older individuals. And it's expected that Pfizer will apply for emergency use authorization in the coming weeks, and then FDA will review that data, and then the Advisory Committee on Immunization Practices and CDC will make recommendations. So we could see a Pfizer vaccine for younger kids later in October or early November. Pfizer has stated that they expect to have data on vaccines for children as young as 6 months later this year. The other thing I wanted to touch on, because yesterday CDC sent out a health advisory regarding pregnant women in COVID, urging them to be vaccinated. They have seen increases in cases of COVID in pregnant women, more than 125,000 laboratory confirmed cases amongst pregnant women. 22,000 pregnant women in the United States have been hospitalized and 161 have died. And in the past 60 days in North Dakota, we've had 13 pregnant women hospitalized and none of them have been vaccinated. And so we just want to urge pregnant women to have a conversation with their OBGYN or family practice physician about vaccination, as it does look like pregnant women are at higher risk for more severe outcomes due to COVID-19 illness. In fact, there was one study published in the BMJ that compared pregnant women with COVID to non-pregnant women with COVID. You're 2 times more likely to be admitted to the intensive care unit, 2.59 times more likely to be vented if you have COVID and are pregnant compared with non-pregnant women. And then in this study, they also compared pregnant women with COVID to pregnant women who are not infected with COVID. And those with COVID were almost 3 times more likely to die, almost 3 times more likely to have a stillbirth. And their infant outcomes, their infants were almost 5 times more likely to be admitted to the neonatal intensive care unit. And so pregnant women are at higher risk for severe COVID illness. Only 30% of pregnant women in the United States have been vaccinated, which is concerning. We're not able to determine what the rate is in North Dakota. And it does look like vaccinating during pregnancy not only protects the mom, but likely also protects the baby who's too young to be vaccinated once born. We have multiple surveillance systems in the United States that are monitoring vaccine safety during pregnancy, including VSafe, which is a smartphone vaccine safety surveillance system that people can enroll in and does regular checks after you're vaccinated. and then also does checks out to 12 months. Pregnant women are able to opt in to VSafe and monitor their outcomes during their pregnancy and afterwards. And so as of September 13th, over 5,000, almost 6,000 pregnant women have enrolled in VSafe. And there was recently data published in the New England Journal of Medicine showing that rates of miscarriage post-vaccination are similar to published baseline estimates in the United States. So the rate of miscarriage post-vaccination was 12.8%. What would be expected would be 10.8 to 14.8%. And so it's within the normal range. And then they also looked at infant outcomes and found that all of the infant outcomes, including preterm birth, small gestational age, admission to a NICU, infant death, were all similar and within range to what would be expected in women who weren't vaccinated. And in fact, there were no infant deaths in the VSafe study group for women who were vaccinated. I also wanted to mention, because I know there are some concerns from women about fertility, that the vaccine safety data link, which includes electronic medical records from 9 health systems across the United States, it's over 12 million records. Right now, they're showing 122,000 more pregnancies between December and July. 10,000 women had at least one COVID vaccine dose prior to pregnancy, and then were still able to be pregnant. And VSafe is also, or the vaccine safety data link is also not detecting any irregular outcomes with pregnancies or miscarriages or anything like that. And so I want pregnant women to feel confident in COVID vaccine, and please have that conversation with your healthcare provider about vaccination. I'm now going to turn it over to Vanessa Riley from the Long-Term Care Association to just make some comments about the planning that has been done with long-term cares to ensure that they have access to booster doses. Vanessa?
Thank you, Molly, for giving me a few minutes here in the town hall to represent the association and our 211 long-term care facilities within the association. As Dr. Carson mentioned, he talked about the fully vaccinated, and I just want to give some props out to our residents who are as of yesterday, 93.63% of residents have at least one dose, and 71% of our staff have at least one dose. Residents, want to make sure that they can continue to live as normally as possible in their congregate living setting and have visitation. This past year, our 18 months was very difficult for them without their visitation. And staff have been increasingly open to vaccination, which helps keep our residents safe and our facilities open for visitation and to protect their own health. As Molly mentioned, about 6 weeks ago, all of our long-term care facilities were surveyed by the Department of Health to determine that they did have a plan for booster doses when they became available. We wanted to make sure that they were ready. We've been watching the news, hearing from Molly, so we wanted to be ready. And as she stated, each facility named a primary vaccinator, whether it be themselves. There was quite a few facilities, nursing facilities, that signed up to be providers, or a long-term care pharmacy or their local public health office, and even some of their medical providers. And then they also named a secondary vaccinator as needed. When we had our initial COVID-19 vaccination program in long-term care back in December, the end of December, first part of January, some of the facilities were signed up with the federal vaccination program, which was a federal long-term care pharmacy agreement with CVS and Thrifty White, which most times they had the Pfizer mRNA vaccine. And these facilities now have a majority of their residents and staff that are eligible to take the booster dose. Facilities that received their initial doses from a local public health or a local pharmacy were more likely to receive the Moderna mRNA vaccine, and currently those resident staff are not eligible for the booster doses. And a small number of residents and staff may have received one dose of the J&J vaccine. Again, these individuals currently are not eligible to receive the booster dose. So as you can see, with the variety of type of vaccine doses that a resident or staff may have had within a facility definitely affects if the resident or staff will be eligible for the booster dose in this early stage of booster dose vaccination. The facilities have been encouraged, once we learned over the weekend that this was going forward, facilities have been encouraged to contact their primary vaccinator and are scheduling their booster doses, vaccination clinics, I should say, as soon as possible. You know, they understand the goal to vaccinate the residents and staff as soon as possible for those that do accept the booster dose. Facilities that use White as their long-term care pharmacy are scheduled to be completed with booster doses by October 11th. So that's great news. And I've already seen on social media that staff are taking the booster dose. We encourage all residents and staff to take the booster dose if they have completed the initial 2 doses and are at least 6 months past their second dose administration. We also continue to encourage residents and staff to get vaccinated if they have been hesitant to this point. Vaccination is the way to keep our residents safe and able to continue their active lives within the facility and continue to have visitation. During the peak of the surge last year in November before vaccination, we had a day where we had 1,600 plus positive cases in long-term care of residents and staff. Today in long-term care, we have 175 positive cases, 46 residents and 129 staff. And this is running about 1 resident every 3 staff. So definitely, if you have a family member that's in long-term care, that you know that your facility is working on getting those booster doses, those Pfizer booster doses scheduled. And if you have not heard, you know, and you're a decision maker for a resident in long-term care and you haven't heard from your long-term care, don't hesitate to reach out to see where they're at with their vaccination program and their booster vaccine. And that's all I have, Molly. Thank you.
All right, thank you, Vanessa. It looks like we have a couple of questions in the chat. And so, Dr. Carson, I think I'll start with you. And I think we get this a lot because, so if someone's vaccinated and has a breakthrough infection, they can, it does look like theoretically they can transmit COVID-19. And so when we say getting vaccinated will reduce the spread of COVID or reduce the strain on the hospital system, what do we mean, or how is that possible if you can still get COVID if you were vaccinated and spread it?
Sure. So there's at least 2 ways that happens. So yes, you can get a breakthrough infection, but there's still some effectiveness of the vaccine against infection. Remember, I showed data that suggested that it's about a 5-fold reduction of risk of simple infection, mild to moderate infection, in people who are vaccinated. There's one substantial way that you decrease the risk of spread, and that's a very substantial way. If you do get a breakthrough infection, it does suggest you know, that you can spread that to others. But there's some interesting data, and I just saw a paper on this morning. I was trying to find it to answer that, and I'm having trouble finding it. Before the Delta variant, we know that vaccinated people carried much lower levels of virus in their nose and throat than people that were unvaccinated with an infection. And household transmission from a person who had a breakthrough infection prior to Delta was reduced by almost half. We were waiting for data on that with Delta because Delta makes a lot more virus. We have much higher viral loads. And the amount of virus in the nose and throat appears to be close to the same in vaccinated people as unvaccinated people at the very beginning. But interestingly, it's a little harder to culture that virus. You can, but you can culture it less often. That's one of a surrogate for ability to transmit. And the amount of virus drops off a lot faster in vaccinated people who have a breakthrough infection compared to unvaccinated people. And I did see one small paper that showed even with the Delta variant, household transmission from a breakthrough case is significantly less than in an unvaccinated case with Delta. So you get it reduced because less people get infected, and you get it reduced because there is some decrease in the amount of virus more quickly and less able to spread it, for example, in households, even if you do break through.
All right, thanks, Dr. Carson. And so the same thing would apply for when we say get vaccinated to protect unvaccinated children or people with compromised immune systems. The reason why we're saying that is because you're less likely to have COVID. And so if you're vaccinated, you're 5 times less likely to have COVID. And then again, you likely will have a shorter time period where you can transmit the virus and could potentially reduce the level of transmission. We did get a question, why is North Dakota not tracking the number of pregnant women who are vaccinated, hospitalized from COVID? We do track that. So if I think I said in the last 60 days, in North Dakota, there's been 13 pregnant women hospitalized with COVID, and none of them have been vaccinated, the ones that were hospitalized. What we don't track is I can't tell you what the vaccination rate is for pregnant women in North Dakota. We don't have that level of granularity in our vaccine coverage rates. And so I can't tell you that 30% of North Dakota pregnant women are vaccinated, but we do know of the pregnant women who get COVID, we do know what their vaccination rate is. Let's see if we have other questions. Oh, we also received a question, does Moderna have a booster yet? So the Moderna vaccine does not have a booster yet. So people who have received 2 doses of Moderna, you're not recommended yet to receive a booster dose. That could change in the future as additional data becomes available. However, I did talk briefly, and this is kind of getting really confusing actually, about the difference between an additional dose and a booster dose. And so if you received Moderna and you're moderately to severely immunocompromised, so if you're on medication that makes you immunosuppressed, if you're being treated for cancer, then you should receive an additional dose because you likely didn't achieve very high efficacy with your first 2 doses. And so those individuals can receive an additional dose of Moderna vaccine 28 days after they complete their initial series. But that's different than a booster dose for people whose immunity has waned over time. We have Kirby and Tim on here. And so maybe you want to forecast this out in the future, but what do you see some of the biggest pandemic challenges the state will experience in the coming weeks? I can start with Tim Wiedrich. I know you've been dealing with some shortages of monoclonal antibodies and hospital capacity. So Tim, did you want to touch on that question?
Yeah, just briefly, those are the 2 main issues that I would speak to. One is that monoclonal antibodies has been a very effective treatment for people with COVID. But the situation that we're now in for our 2nd week and soon to be our 3rd week is that the demand for monoclonal antibodies nationwide is outstripping the supply, and therefore we are in fact running out of monoclonal antibodies, and that allocation process that we're receiving within the state does not cover the demand that occurs within the state. So again, the best way to just underscore once again, the best way to resolve the situation is to become vaccinated and not become ill in the first place so that you need monoclonal antibodies. And then the second issue relative to the hospitalizations, again, I think speaks for itself, as we have the staffing shortages that we're experiencing, the increased utilization of hospitals. The entire system is stressed. We've heard hospital officials and physicians repeatedly telling us, the public, that the system is under stress and encouraging vaccination, and for people to do everything that they can do. This doesn't just impact people with COVID. Hospitalizations are up across the board. Other types of medical emergencies like strokes and heart attacks are still occurring, trauma is still occurring, and all of those factors along with COVID are creating a great deal of stress in the hospital system.
Right, thanks, Tim. We did get a question if we'll be putting booster dose data on the state's COVID vaccine dashboard. And yes, we are currently working on adding booster dose data, third dose data to our dashboard. So be on the lookout for that. We also got a question about where to receive boosters. And that's a good question that I want everybody, of course, to know. So many providers in North Dakota, I would actually say most providers in North Dakota are already giving Pfizer boosters. And so you can go to vaccines.gov to find a provider near you who has COVID vaccine. But pharmacies are giving booster doses. A number of private healthcare providers, you can contact the doctor you usually go to. And then local public health. Most of the local public health units have also started giving booster doses. And in the very near future, the North Dakota Department of Health pop-up clinics will also start administering booster doses. And then, of course, if you have any problems finding a booster dose, please reach out to the North Dakota Department of Health hotline, and we will work to find you a booster dose, even if you're homebound. We also got a question about, I had mentioned over 8,000 North Dakotans have already received a booster dose. So over 8,000 North Dakotans have already received a third dose of COVID vaccine. So that includes individuals who were immunocompromised and were recommended to receive a third dose. And then it also includes people who started receiving booster doses late last week. And actually, most of them, I would guess, are not living in long-term care facilities, as the long-term care facilities are just starting to get access to booster doses this week and next week. Let's see. Do you have, and Dr. Carson, I don't know if you know this, but do you have any information on the effectiveness of boosters for those who are breastfeeding along with their infants?
No, I mean, that wasn't a group that was studied. That wouldn't be a group by and large that would be eligible. Those are going to be young people, and unless they have some other underlying medical condition, they wouldn't be eligible for a booster. There is data that shows women who are breastfeeding and receive the vaccine, it appears to be safe for the mom, safe for the baby. And maybe you know, Molly, whether about passive antibody transfer, maybe you can comment on that.
Yes, it does look like women who are breastfeeding and were vaccinated can pass on antibodies that could protect their newborns. And then one more question, Kirby, I don't know if you know the answer to this. If not, I can try and take it. But on the data that looked at the counties with higher vaccination rates, or the outliers on the data that you showed, where most of the counties with higher vaccination rates had lower hospitalization rates, there were some outliers like Slope or Emmons or Nelson. Do you have any idea about why there are those outliers?
Yeah, that's a good question. And I think anytime you look at data like this, you always end up with some outliers. But, you know, we have to take into consideration other factors that might be playing into some of this, you know, the age structure of the county and other risk factors for disease in a particular county that may not be fully accounted for, and just looking at a correlation study. But no, beyond that, I don't have definitive answers for those outliers. And I don't know, Dr. Carson, who is involved in academics and studies, I don't know if you have anything more to add to that. So
you're right. Actually, whenever you're right, when you look at that big of a data set, that many data points, you almost always have a couple of outliers that defy a very good explanation. And that's why we look at, you know, more the core overall trend, and that is pretty clear.
Yeah, and in my conversations with the Office of the State Deputy's Office, it does look like some of it might be small numbers as well for some of the more rural counties. So, all right. Well, I think let's see. Oh, one more question, and then I think this will be the last question, and we'll have to end. The question is, I am immunocompromised and have had both Moderna shots. how do I go about getting my extra shot and where do I go? Well, you can call our hotline if you're having trouble finding Moderna vaccine. But you can also go to vaccines.gov and put in your zip code and that you're interested in Moderna vaccine, and it'll show you a list of clinics in your area that have the Moderna vaccine. But most local public health departments, pharmacies, and healthcare providers all should have that vaccine and be able to vaccinate you. But you can also always start with your healthcare provider as well that you normally see. So I think I will end the town hall today. I want to thank all of our speakers for attending and everyone who attended live. And I hope we were able to answer most of your questions about COVID-19 booster doses. We will be posting this on our social media and then on the Department of Health YouTube page for viewing at a later time. So thank you, everyone.